going to talk about our next emergency medication, which would be epinephrine, the EpiPens, which we are using to treat the severe allergic reaction, referred to as anaphylaxis. You're fine. No, keep on going. We're good. So, just some kind of quick definition. So this is caused by an allergen, which is basically anything that can be introduced into the body, whether it's through ingestion or contact or inhaling something that these are normal things we all come into contact with, but certain individuals have essentially a runaway or an exaggerated reaction to the presence of that allergen, and it causes problems, which we'll identify in the next slides here. But some of the common things that cause these are your foods. So this is probably going to be one of the most common, tree nuts and those types of things are the things we see most common with students, but also things like insect bites. Sometimes, latex, I haven't seen that on too many of the students that we have in terms of that being a severe allergic reaction, but we'll also see other things like just sort of generic environmental allergens. So these could be like, grasses or pollens or something like that in the air that a lot of students will have responses to. And it's going to be key in that our ability to kind of assess what's going on with that student to tell whether or not they're heading towards an anaphylactic reaction or whether this is just kind of sort of your more normal like seasonal allergy type things, and we'll talk a little bit more about that next. So again, anaphylaxis, this kind of runaway response, this allergic reaction, is a life-threatening emergency. We want to intervene as quickly as possible, because if we let this go unchecked or we're not really sure and we kind of hold off on treatment, this could be life-threatening to the student. Usually one of the key indicators as to whether or not this is sort of a normal standard allergic response or heading towards anaphylaxis is going to involve multiple body systems. So you're either going to see something extend beyond the sort of point of contact. So let's say it's an insect bite or a sting. So rather than seeing kind of a localized reaction within that area, you're going to start to see it spill over into other, starting to spread up their arm. Or if it's some other type of environmental allergen, it's going to manifest on, say, maybe their face and also on their chest or on their arms, and it's starting to kind of spread and go what we call systemic, which is meaning throughout the entire body. That's telling you that this allergic response is not just being kind of kept in-house where that particular exposure occurred, but it's now starting to involve the entire body system there. So the signs that you're going to kind of start seeing, depending on what the allergen is or where the student was exposed to it, the main one is going to be kind of difficulty breathing, and this is going to be related to a few different things that we'll talk about that's happening within the body, but you're going to have that either high-pitched or kind of wheezing type of sound that you're going to be hearing. You'll be able to see, right? We know kind of what people struggling to get breaths in kind of look like. You're going to start seeing stuff like that. An inability or difficulty in swallowing or being able to talk. You'll see that also swelling in the face, usually in the cheeks, around the eyes. Those are some of the more visible places to see it because we've got a lot of bony structure around here, so the swelling doesn't have a lot of places to hide, whereas swelling in the arms or in the chest or in the legs might be a little bit harder to detect, but you'll really notice it in the face. Their pulse will be up. You guys aren't going to be checking pulses though, but it's just important to note that that's kind of what's happening physiologically here. And they're going to start feeling a little bit, dizzy or, like they're about ready to faint or unsteady on their feet. It could be, depending on where you get to this individual, that they've already lost consciousness, if this is something that we didn't immediately witness and come upon the patient, or they're going to have some abdominal pain, flushed skin, and some sweating. Hopefully we won't see the incontinence piece of it, but so this is what's happening to cause all of those symptoms before. So when you have this runaway allergic reaction, the body's producing histamine, which goes out to the cells, and in response to that histamine in the cells, we get three main things that happen. The first one is, well, I'm going to go in reverse order here because it makes a little bit more sense. You get this vasodilation. So these are your blood vessels in the body. So this would be normally kind of what they look like, and in the presence of this histamine, they essentially enlarge. So what this causes systemically, again, is a drop in blood pressure. So when the person is weak or they're disoriented or they're feeling a little bit faint or lightheaded, a lot of it is related to the drop in blood pressure, right? So suddenly you have a lot more space for the blood to go than it had before, and the blood is having a lot harder time crossing the membrane between the blood vessels and the organs and the muscle tissue that it normally goes to. So, you know, your brain, your liver, your lungs, all the stuff that need this blood flow, you're gonna start seeing those effects related to this increase in vessel size. At the same time, in the lungs, the opposite thing happens, and these large airway passages in our lungs start to become constricted. So, you know, if you're, normal breathing, and now suddenly you're having to breathe through something like, a coffee stirring straw, and how much more difficult that is, that's what's happening in the lungs. So that difficulty breathing is going to be related a lot to this, and that sound of that wheezing kind of nature to their breathing. There's also something we call capillary permeability. Essentially think of it as like a leaky pipe. So your blood vessels, in addition to getting larger, also start losing fluid outside of the blood vessels, and it starts escaping or leaking into the tissue surrounding the blood vessels. This is that edema or that swelling that we see in the face. So these things work in conjunction a lot, right? Narrowing of the air passages, suddenly the space around, especially the upper airway, the necks and the cheeks get larger. Well, that's making it even harder to get air in and out. So you're having a hard time getting air in and out in the upper airway, and also down in the lower airway in the lungs. So the difficulty breathing is going to be one of the key things that we look for when we're trying to determine, is this person having an anaphylactic reaction. Okay, so again, recognizing these symptoms and saying, okay, this is a little emergency or this is a big emergency is going to be key, because we want to get that medication, that epinephrine, on board as soon as possible to start reversing these types of effects. The longer we wait, the harder it's going to be, the worse off this person is going to be. And just like with the Baqsimi, if we're having a severe allergic reaction, we're calling 911. Even if we're able to get an improvement in the symptoms, which we're hoping for with the administration of epinephrine, this person is going to need to access 911 because they could have a relapse. Again, once the medication wears off, they could go right back into anaphylactic shock. So we don't want to just assume that if their condition improves with 1 or 2 treatments that we're good and we'll just call mom and dad and come pick them up. We really want to have them access 911 services. All right, so the treatment protocol, we'll play with the pens here in a minute, but what we're doing is trying to determine first, is this person suffering from an anaphylactic reaction, or is this, again, kind of more on our scale of, a sensitivity or something like that, but we don't need to administer an emergency medication yet. If we do determine this is, anaphylaxis or heading towards that, we don't want to move the person, right? Again, we're talking about a lot of compromise to our cardiovascular system, our blood flow, and our ability to breathe. So any additional movement is going to be much more difficult and more dangerous for this person. We want to get them to a position where they can lay down or sit down and be safe, protect themselves from further injury, and decrease their level of exertion. We want to select the proper epinephrine pen. Now, these are all prescription. So our individual students should come with the pen that has been prescribed to them by their provider, and that includes the dose. So some of you may notice in those trainers you have, are there any left with the, everyone listen to the green one, if there's a green one? For the video, since you have see. So the most common formulation that we see in the schools are these EpiPens, and there may be different ones. But you'll notice, based on the color of the cap here, these are just indicating different dose. The usage of these things are exactly the same between one or the other. One is just formulated for people who are going to be under 66 pounds, so these are going to be primarily our kiddos, in the elementary school. And by the time we're getting to, middle school and high school, we're definitely going to be using more of an adult dose. And we'll have a chart that kind of shows what those things are. So if you don't have the one that came with the child for whatever reason, can't find it on their person, or it got lost in the shuffle or something like that, but you have access to one of these through some supply that comes through the school, feel free to use that. And if you have the option to use one or the other, trying to select it for the child based on their size is good, but honestly, in a severe allergic anaphylactic reaction, you can use either one of these. So if all you have is a junior and you're dealing with a big kid, it's better to use what you have than nothing. And likewise, if you're dealing with a smaller kid and all you have is an adult-sized dose, again, better to use that than not. But ideally, the providers will determine which of these is appropriate for the child, and you'll have that available to you. Okay, so we're going to administer the epinephrine through the device. We'll talk about the mechanics of that next. If you are alone, then this is something you want to get on board and then access 911. You don't want to delay giving this medication in order to go find a phone or go find somebody to call 911. Give this medication, but we do want to make sure that 911 is going, so ideally you'd be with someone else, that while you're helping the child administer this medication, someone else is going and making sure that 911 is being activated and health services is also being notified. We want to note the time that the auto injector was used, not only so that we can determine when a second follow-up dose may be utilized, but also when 911 gets there, they're going to want to know epinephrine has been administered and when that was, so again, they can follow up with either an additional dose of epinephrine or some of their other medications that they can use. If there's a stinger present, right, if this is related to an insect bite, you know, and it's visible and there it is, yeah, please remove it so that we stop introducing more allergen into that individual. That won't always be the case. So we're going to be checking and trying to maintain the person's airway and breathing. For what that looks like for you guys, again, getting them into a position of comfort. So a lot of people will assume some sort of position that feels easier for them to breathe. A lot of times if you're sitting down, they'll kind of do what we call the tripod position. So they'll kind of be bent over and they're going to be basically trying to access those accessory muscles to help open their diaphragm up. So whatever that works for them, similar to the Baqsimi, we want to try and protect their airway. So if they've gone unconscious, we don't want to just lay them on their back in case there's any secretions or anything like that that they might aspirate, so move them over onto their side. But we're really just trying to do the best we can to, you know, help assist them in getting air in and out of there. Monitoring for change in the person's condition. So this is what we're going to determine whether or not they're getting better, staying the same, or getting worse, as to whether or not we're going to follow this up. So if they're continuing to go, you've seen the swelling and it's continuing to increase, or it's not getting any better, their exertion level in terms of breathing doesn't seem to have improved. You're still hearing all those sounds of them having difficulty getting air in and out. After the 5 minutes, we may need to administer a second dose. So we're just kind of monitoring for those changes. Again, this is going to be good information for EMS to have once they arrive on scene. Say, hey, at this time I administered, you know, 1 dose of, you know, epinephrine. You have the container hopefully still with you. You can even give it to them so they can, you know which dose was given to that patient. And this is what I've seen since then. Their condition is getting better. It's getting worse. It's stayed the same. Nothing has changed. Again, that's going to be useful for them to know whether, you know, what drugs to give to that individual next. All right, so here's the actual EpiPen. So there's a few others in the trainers there that we'll kind of pass around so you can have an idea. But these are the ones commonly on the market. You've got the, all of these are going to work very similarly in terms of their general mechanics. We've got kind of your generic formulation and the EpiPens. We'll talk about the nasal formulation next, but usually what you're going to have is some sort of safety cap on these, whether it's on the bottom with the ABQ or with the epinephrine pens, they're on the top. But these are going to prevent accidental discharge until you're actually ready to administer the drug. So whether it's on the bottom or it's on the top, I think the next slide here we've got, yeah. So we're taking the auto injector out of its protective case, whatever that looks like, removing the safety cap. So again, on the top or on the bottom, wherever it is. Cori's favorite line is blue to the sky, orange to the thigh, right? Because apparently people are having a hard time figuring out which end goes in which. And you're basically going to grab it right around the middle, again, to make sure that your thumb or anything isn't obstructing wherever the needle is going to come out of this particular device, okay? So we're either going to hold it against the thigh. Most instruction will have you sort of swinging your arm to make sure that you get enough force to get this into their thigh. These are spring loaded, so even just pressing it against the thigh will get the needle into there. It's not because there's a needle there and you need to make sure that you stab it hard enough to get it into their leg. Usually your adrenaline is going to be going in this case, so you're not going to have too much of a time applying enough force to get this into the person. We want to come in at a 90-degree angle against the thigh, the big muscle group. This is an intramuscular injection. The reason it goes so deep into the muscle tissue as opposed to some other medications like insulin that stay closer to the surface is we want rapid absorption. We want this to hit as big of blood vessels as possible and get into the circulation as quickly as possible, and that's that big muscle group there. It's the easiest one to access, especially through clothing. This can go through jeans or other light clothing, but if for some reason this your kid was wearing lots of layers of clothing or something like that, we may need to get down a few levels in order to get that. That might be something to look for if you've given a dose and you've not noticed an improvement in their condition. Is, okay, were they wearing so many clothes that I didn't actually get this down in there versus, you know, shorts where it's like, okay, I'm positive that this got into the skin. But just kind of assess for that. We're gonna hold that in there after you hear that click, right? You take the safety cap off, you should hear the click that lets you know that that's the spring-loaded device that has actually sent the needle into that patient's muscle tissue. Hold it there for say 2 to 10, 3 to 5 seconds, just to make sure that all the medication has been administered from the auto-injector into the thigh, and then you'll remove it. In most cases, this will extend beyond the needle, so this is sort of your safety. Still just treat it appropriately after you're done. Keep it around so you can provide this to EMS when they get on scene, and then we're just going to kind of lightly massage the area afterwards to again help facilitate that absorption into that large muscle group and get that medication into the circulation as fast as possible. All right, so yeah, place of active protective case if you have it. We're massaging. 911 hopefully has already been called, and then we're again noting the time so that we know when a repeat dose can be given and to also pass that information along. These are the different formulations that you see. We don't have any of these on site. These are for little babies and that type of thing. But these are the difference between the green cap and the regular yellow cap EpiPens. It's either 0.3 or 0.5. You don't need to worry about the dosing. Again, hopefully these will be appropriate for the child and come with them prescribed, but just know that that's kind of basically you're dealing with either a full dose for 66 pounds and over, or it's cut in half for the little kids. But if whatever you have is whatever you have in the event of an anaphylactic reaction, give it to that person. So this is what the epinephrine is essentially doing. Epinephrine, essentially adrenaline, right? This is kind of our fight or flight response hormone in our bodies. So it's constricting blood vessels, it opens our lower airways and reduces swelling. So if you remember what anaphylaxis does, we talked about the vasodilation, the bronchial constriction, and increased membrane permeability. It's doing it's a perfect drug to do exactly what we want. We've got a drop in blood pressure. This is going to constrict those blood vessels back down and get our blood pressure back up, hopefully get that person's level of mentation back to where it needs to be. It's going to help reduce that swelling, especially around the upper airway where it's causing problems with them breathing, and it's also going to cause those airway passages lower down in the lungs to open back up. So again, the exchange of airway is going to go a lot easier for this person, and it should be fairly rapid, right? You should notice the effects of this, within certainly, a few minutes. There are some side effects that go along with epinephrine. So when you're assessing this patient as far as I gave the medication, is their condition actually improving? You might start seeing some of these things in terms of, we've all had those kind of adrenaline dumps, right? And those kind of after effects of feeling a little bit shaky and a little bit, you feel like your heart rate is a little bit up there. Maybe you'll have, a headache, or there may be some sweaty or some GI upset. All that's fine, right? We can live with that. What we're really trying to make sure is we're reversing those, especially those breathing signs and symptoms, the difficulty breathing, the wheezing, the swelling up and around the face and the upper airway, and the mentation, the loss of consciousness, and feeling kind of dizzy or lightheaded or unstable on their feet. If we're seeing a reversal of those symptoms, great, that's what we want. We'll live with this stuff, and it could last anywhere from 5 to 20 minutes because epinephrine is a fairly short-acting drug. So this is again why we want to make sure 911 has been activated, because if after that drug wears off, if they're either still being exposed to that allergen or it was such an exposure, they're so sensitive that they're likely to revert back into it, we're going to either need to follow up with another dose of epinephrine or other more long-lasting drugs like IV Benadryl and those types of things. All right, so we have a couple of scenarios here that we're going to walk through here just to kind of get you thinking about what you might see and whether or not this individual would be appropriate for an administration of epinephrine. So scenario one, we've got a 15-year-old stung by a bee on his calf. The area is the size of a nickel, red, swollen on his calf. No swelling or redness found anywhere else. No hives are seen. He tells you this is the first time he's ever been stung. Are we thinking epi or no epi?
No.
Okay. Excellent. Correct. So this is a normal reaction. We talk about those localized reactions. Didn't expand beyond, start running up his arm or anywhere else. He's not having any difficulty breathing. He hasn't said that he has a sensitivity to bee stings, or it's at least not known at this point. So the risk is low. We're not saying he couldn't. We're not saying that this couldn't change and suddenly be something different. But based on the way he's presenting right now, we're not reaching for the epinephrine. All right, scenario two, we've got an 8-year-old that has hives on her neck and chest. She's scratching at them. She appears to be breathing normally. She ate a cookie 30 minutes ago, a friend gave it to her, so we're not exactly sure what may have been in that, and she has a history of allergies to peanuts. She has an EpiPen Junior prescribed to her. Are we thinking epinephrine in this case, or no? I see some head shaking, no?
Yeah.
Why is that? What's our thinking?
She's breathing normally.
Okay.
I would observe her and watch her. And
Yeah.
then call home. Call.
And definitely call.
So, you're right, the breathing is good, right? We like the fact that she's breathing normally. The fact that she's ingested, let's call it an unknown substance, so cookie, there's a high likelihood that there's some sort of nut involvement there. She has a history of allergies to peanuts, has been prescribed an EpiPen Junior, and we're noticing signs and symptoms in multiple body systems. So this is someone who is heading towards an anaphylactic reaction. I'm gonna go to the next slide there. So in this case, this is something we would probably want to go with epinephrine. This is a drug that has very low side effects, very low risk. And the benefits of administering a medication to a student before they develop the difficulty breathing, this is not one of those things where we want to be like, we're going to wait for you to get really bad, and then we'll give you the drug that you want. We're going to hope that, in a few minutes later of having, struggling breathing, you're going to get better. We want to utilize these, especially, and if she didn't have that history, right? If she didn't have the EpiPen, if she didn't have a known allergy to nuts, and she just ate a cookie and she's having those hives, I would probably agree with you, and she's not breathing normally, say, okay, let's hold off on that. But if we know that history, and we know that she has a prescription for an EpiPen Junior because of a severe allergic reaction, she told us that she ingested a cookie, she's starting to have those systemic signs of anaphylaxis, this would probably be a case to better give the epinephrine, especially if it's an EpiPen Junior, and then continue to monitor her than not.
I have a question. My son has a peanut allergy, so we've done this whole thing since he was like 2. But like when he's been exposed, like we automatically just do Benadryl or something like that, and then that usually dissipates all that. And like he's never had an EpiPen, but he's had allergic reactions, vomiting, all of that, and we just administer Benadryl and then it goes away.
And these are not perfect scenario, right? There's no black and white thing because everybody's sensitivities are going to be a little bit different, right? So, even if they have a severe, or have been prescribed an EpiPen for a severe allergic reaction, their level, right? Is it just, contact, right? We have, nut-free classrooms because some people just literally can't even touch that or else they're going to go
Which
right
is
through
like
the
my
roof.
son, like you touch it, he'll get hives, he'll do. But we've always been told you go to Benadryl or,
Because a lot of our kids come with Benadryl.
A lot of
It's actually the opposite though. You're supposed to people give epinephrine way less than they probably would be advised by a doctor. You don't have to wait for the emergency for people with those known allergies. And like I would guess if vomiting was going on and you did go to the doctor, they would not object to an EpiPen being used.
Yeah.
But you were able to manage it that way, like
We've always done it that way, and I don't know, maybe.
And if you have that level of knowledge, because it's your child, and you know how they respond, I would say that you're not managing it incorrectly. But if we're dealing with more of an unknown, this child that we're maybe familiar with, but not that intimately about, we've dealt with multiple allergic reactions and exposures, and we know that this is how they respond. Erring on the side of giving epi, again, this is not a drug other than those side effects that we mentioned, where they're going to have a little bit of an elevated heart rate, might get a headache, they might feel a little bit nervous or shaky. This isn't going to harm the child. So we're better off in that situation where we think, it could to give epi, and maybe be wrong that was like the thing to do, because this isn't going to harm the child. And then follow it up with some Benadryl to make sure that we don't ever get to that point where suddenly that child's airway has closed off and they're having difficulty breathing. We think, ooh, okay, I guess in this case I should have given epinephrine. So it's a little bit more of we're trying to recognize those signs and symptoms and make a rule that is general enough for a large school population, and know that there's going to be these outliers of like, well, in my case, I do fine with just, oral administration of Benadryl, because Benadryl does take a long time, right? Especially if you're just ingesting it. It takes a long time to get going. So the reason that, the thought for the epinephrine is it's fast acting, we want to get that on board to reverse this person from heading further downhill rapidly. And again, people's sensitivities are going to determine how quickly they go downhill. But, we're assuming that we are operating with more limited knowledge than we would like.
So the process is anytime you do an EpiPen, then you call 911, and that's just protocol, right?
Oh yeah, for sure. Yeah, if you have enough evidence to suspect this child was having or heading towards an anaphylactic reaction to the point where we administered Benadryl, get 911 going so that they can monitor and follow up.
And I think even though it's called an emergency med, we're actually preventing an emergency is really like the use of it. Because this is able to reverse those symptoms, whereas like the Benadryl is really gonna block like more production of histamine, but the effect that that histamine is already having on the body is not gonna get reversed from Benadryl. The epinephrine is going to reverse the things that have already occurred. And it seems like we kind of try to avoid to give it, and we don't need to make a case not to give it. If someone has a known allergy and they're presenting signs that are around the airway, that's like, you can't know for sure what's going on internally. So if it's around where their breathing is, it's fair assumption to say that it is affected on the inside too. That there's likely swelling going on that we can't see. And even though they're presenting really good and stable, we're preventing it from going further. We're like, we don't have to wait till it gets there to do it.
Well, and my only thing is, which that's fine, is we know the community we live in, and we know some parents' reaction to us. If it's like, I didn't want you, I specifically said you were to give Benadryl first. I do not give you permission unless they're on the verge of death. We have parents that would respond that way.
I would get us involved for sure.
Well, which we would, I'm just saying.
I'm happy to have that conversation of why I decided to give your
The
child
protection on our
versus-
side with, of parents coming after us personally or whatever, because we did this. Because of the orders and the allergy and the protocol and all that, we are, this is a stupid question, but we are protected of making that call. I'm not a nurse, but I am trained to do this based on the reaction, so we are
And we have a
protected in
student,
doing so.
Yes,
Across
you are
the
trained to
street.
administer this medication in this manner, in that situation. As long as you're not, deciding that, well, it doesn't look like anaphylaxis, I don't see any reaction, but you know what, I have a key that I'm just gonna have some Benadryl and see what, or have some Epi and see what happens. Yeah, then and there are times, there was a slide, I think I may have taken it out of this, where epinephrine's been used to treat asthma. Severe asthma, for the same reason, right? Broncho inhalers, right, that's what they do, is they allow those airway passages open back up, which was one of the side effects of Epi. So in lieu of having access to an inhaler, people are like, well, just do Epi, it does kind of the same thing. That is a no-no, right? That's using the medication in a manner which it was not intended, and those types of things. But for what we've trained, or what we're training you guys to identify the signs and symptoms of an anaphylactic reaction. And again, we're talking about situations in which there is some judgment that needs to be, and if we have the time to, even get a phone consult with us, which would be ideal in that type of a situation, we could say, yeah, administer epinephrine. Then again, you guys are covered, and I will have every conversation with a parent about why I opted to give a life-saving emergency medication to their child, then wait for them to get on death's doorstep because they didn't want to, they wanted to see what happened with Benadryl. I'll have that conversation.
And it is fair. Last year at Huxley, there was similar, parents are so close to, they want to come in. A parent did come in. I was kind of like, we could make a case for giving it, but you're here, it's up to you. She took the student out, they got in the car, they went to the ER, got Epi. And the student was able to talk, like had hives, like seemed like relatively stable. Probably you guys wouldn't be thinking, I want to poke this kid, but that's the route it went when she went to the doctor as well. So it doesn't have to get to like a terrifying level for it to be used. They are going to use it, and the advice that was given to that parent later was, don't wait, give it. So that is kind of the training that they're trying to get across. I would actually say that a lot of parents with kids with EpiPens try to avoid using it, and whether it's the cost or it's just scary to give a child an injection, that it is used far less than a doctor probably would recommend.
Well, yeah, because I would say when I started with my kid back like 18 years ago doing it, it was give him Benadryl, give him Zyrtec, do that when you see the signs, and then if you need to, give an EpiPen. So that's just the protocol we've always done.
And if you're able to get to it, like if there's been an exposure to a known allergen, and you start to see those signs before they've really started taking hold systemically, and you can use an antihistamine, so that's a histamine blocker. So if you can sort of push pause in the middle of this runaway allergic reaction before those symptoms are starting to manifest systemically, then that would work. But that's going to rely on you being kind of Johnny on the spot right there as this thing is going on. So in some of these scenarios where we may not get involved until later on in this process, and as Cori pointed out, the histamine release has already happened to a level where the signs and symptoms are manifesting systemically. By the time we're able to ingest oral Benadryl and get those histamines to actually stop, by the time it actually is able to stop those, we may be dealing with signs and symptoms that will only be reversible via epi at that point. So normally, like our protocol, like an emergency scenario, is give epi, follow up with Benadryl, right? Versus kind of the opposite way. And again, I don't know if it's, just people have a hesitancy to like, this is an emergency, but only but the risk reward of using this versus not using it is, again, a little bit of shakiness, a little bit of an elevated heart rate, maybe, a headache or something like that, but the potential life-saving benefits are getting to that person where they're not sitting there trying to gasp for, for air. I mean, yeah, well, why wouldn't you, right? So I think there's been a lot of change in that kind of thinking of, especially like educating parents, with children with severe allergies of like what to do first and that type of thing. And we've certainly seen like the epinephrine, like, don't be afraid of the epinephrine. Use the epinephrine. It's like AEDs. People were very afraid and still are a lot of times to like apply AED pads to people because they're like, well, and they may not need it. I don't want to do it. It's like, no, please do. You're not going to hurt this person if they truly need, an AED or in this case epinephrine. Use it. You're not going to do more harm to that child by giving them epinephrine when they didn't need to. And if we have to incur the wrath of some parents as a result of it, again, I'm happy to back you guys up if you're using, epinephrine in the way that we've kind of described.
So is it okay to give like an epinephrine and then like 5 minutes later give them Benadryl when they seem,
if they've come back around, yeah.
Yeah.
I mean, in 5 minutes down the road, if you've needed to give Benadryl, hopefully EMS is going to be there pretty quick, and they're going to be able to make that decision about what route to get. Because I mean, you have different routes, either orally or they're going to start an IV and give them Benadryl at that point in time. So, but yeah, if you are at camp and that's not an option, and they're much further away from that, and they're able to take it for sure.
Benadryl so close.
Yeah, and you can get the Benadryl going on board, and if they still are, or somehow revert back to, more signs of anaphylaxis later, you can still follow up with another dose of Benadryl, of epinephrine, even if the Benadryl is on board.
And if there are those parents who are nearby who are adamant, do not use that EpiPen, I'm coming, and they wanted to deal with taking them or get them checked out themselves, still likely get us involved so we can just let them know the risk of that could happen during the drive and the instructions of like pulling over, calling 911. We really want to make sure that they know like if they're choosing to transport and forego the medication, that if we're thinking that it might already be necessary, that it could continue to increase on their drive and that they should pull over, call 911 should anything change.
Okay. These are great questions, though. Yeah, so these
Certainly
are
refuse minutes.
these are nuanced things, and again, we're asking people to use a little bit of kind of judgment in a lot of these scenarios. But all right, 3. A student tells you that another student was stung in the face after poking at a wasp nest with a stick. The child who is stung is screaming, "It hurts!" repeatedly, and he's got a swollen upper lip and cheek. Are we thinking epi or no in that case? Now I got y'all thinking,
I don't know.
I knew
I'm guessing
before.
so.
I thought I knew.
I would say no.
I
No.
would say no.
Yeah. Nope. You guys are right. So we're talking again about a localized reaction. So just because of the location of where the sting is and it involves, the face and the upper airway, it's going to, seem worse in a lot of cases than if it's on the leg or an arm. It's kind of like, that's no problem. It's like, ooh, face, that's bad. But again, we don't have any indication that this individual has a previous, known severe allergic reaction to stings. They're not having any respiratory difficulties. They're just saying, ow, it hurts. So yeah, again, not that this couldn't go down, right? So this isn't necessarily someone that we, wouldn't want to kind of continue to monitor for a little bit, but the risk of developing anaphylaxis is low, so we're holding off on the epi. All right, last scenario. A staff member directs you to help another 24-year-old staff member. His lips are swollen. He's struggling to breathe. You hear wheezing sounds. He feels dizzy and wants to pass out, and he also feels like he's going to throw up. Yeah. So this one's, this is sort of your classic. We have the classic, this is not a big deal. This is your classic, like, you couldn't check more boxes that this person needs emergency
24,
epinephrine.
sure, what did you do last night?
Well, it was just the dizzying passing out and vomiting, but we'll have a different thing.
Oh,
But
it's scary.
yeah, especially, and again, what we will likely, I think what most people kind of naturally key in on more on these things is that difficulty breathing part, right? Like Cori said, somebody coming in and saying, I'm a little dizzy, I feel sick to my stomach, that happens all the time, but it's suddenly the, I feel like I'm about ready to pass out in addition to the fact that I'm struggling, to breathe and wheezing. That's what's really, keying us in that this is a case that needs epinephrine, and don't waste time getting this on board.
And comparing the swollen lips here versus localized, where it was just a sting on the lip, there's a reason for that swelling. Like swelling in the lips without having like a mechanism, that's different.
Yeah, no mechanism. So again, just kind of in summary, anaphylaxis is a life-threatening event if we don't, the earlier we can intervene, and these are earlier, again, risk reward of using epi versus not using epi. There's not really a case to be made other than people's predisposed thoughts about when this should be used or maybe a cost. But if we're talking about, again, potentially giving life-saving intervention to a student and preventing them from going down that path, I will back you or anybody up all day long as to why you chose to give epinephrine in those cases versus wait to see what happens and then wait for them to get really bad. There's just too much, right? I mean, Cori and I have background in emergency medicine. How many times have we run into people who were in the middle of having heart attacks and waited and waited and waited because they just thought, oh, it's not me, it's right, it just can't possibly be it, and they waited too long to access medical services. We kind of naturally have this disposition.
Out of the kindness of their heart, though.
Thinking that we didn't have anything to do. So don't hesitate to give epinephrine in any of these types of scenarios. So, and then I think the next video we're going to talk about is Narcan, and hopefully the video will work this time.
So just really quick one question. So they're gonna give, I saw on one of the slides, they're gonna have nasal spray epinephrine?
Oh yeah, sorry, thanks for reminding me. Yeah, so it was just approved by the FDA, the nasal spray formulation of epinephrine called Neffy. So hopefully before too long, all the emergency medications that we need to administer are all just gonna be sticking tubes up people's noses. Wouldn't that be great? But it is not on the market yet. We don't know exactly the time frame that it's going to take to actually start getting these out on the streets, and which providers are going to prescribe that formulation to the kids. The dose that was prescribed is the adult dose though. It's for 66 pounds and over, so no dose for children or patients weighing less than that has been approved yet. So if we do start seeing this soon, it's likely gonna be for that demographic, which for you guys, that might be, more in your ballpark than the folks at the elementary schools. So once we start seeing that, then we'll incorporate that more into the training. But it will likely look, the Baqsimi looks a little bit different than the nasal spray. They all work, as you'll see in the video, they work very similarly. But the packaging will just probably look a little bit different. Neffy might be, similarly that way. But it's not here yet. But yeah, hopefully it is coming soon.
One thing too with the epi, important to know is that mostly it'll be with the student's prescriptions, but this is a medication that if you have reason to believe that any student is suffering from an allergic reaction, we can use those stock ones. If there's a good reason to think that they ingested something or exposed to an allergen and that's the reaction going on, then you can use one of the stock ones.
Yeah, because we'll have, you don't know you're allergic to something until you start having an allergic reaction to it, right? So, I mean, there might be just that kid out there who has not been exposed to that thing that is going to cause, and there's also exposures that occur that nothing happens, and then upon re-exposure to that, that's when that sensitization occurs, and now they have that anaphylactic reaction. So just because we've been in the clear in the past doesn't mean we're going to be in the clear in the future. It's just that in those scenarios where there's a known anaphylactic reaction, that increases our likelihood of reaching for this medication sooner rather than later. But it doesn't mean that it can't, like Cori said, go to somebody who's never had an anaphylactic reaction before. We're authorized to use this in any of those situations.
And switching gears, here we go.
Using nasal naloxone to reverse opioid overdose. Naloxone is a medicine and is also known as Narcan. When someone overdoses on opioids, they stop breathing. Naloxone reverses opioid overdose so they can breathe again. Opioids include drugs like heroin, methadone, Oxycontin, Vicodin, Percocet, codeine, and fentanyl. Naloxone does not reverse overdose from drugs like cocaine, meth, alcohol, or benzodiazepines like Xanax or Valium. Step 1. How do you know if someone is overdosing? There are several signs. Not breathing, or breathing is very slow or shallow. Turning pale, blue, or gray, especially their lips or fingernails. Making snoring, gurgling, or choking sounds. Becoming limp, throwing up, not responding to yelling or other stimulation. The quickest way to see if the person is responsive is to take your knuckles and rub them firmly up and down the person's chest bone. If the person does not respond, check for breathing. Watch their chest to see if it rises and falls. Put your ear near their face to listen and feel for breaths. Step 2, request medical assistance. If the person does not respond and is not breathing, request medical assistance immediately. There may be complications that need medical attention, or the person may have overdosed on something besides heroin or other opioids. Emergency medical services are critical. Step 3, CPR. Place the heel of one hand over the center of the person's chest. Place the other hand on top of the first hand. Keep your elbows straight with shoulders directly above hands. Use your body weight to push straight down at least 2 inches at a rate of 100 compressions per minute. Give 2 rescue breaths for every 30 compressions. Continue CPR. Step 4, give naloxone. If the person is still not breathing, it is time to use your naloxone. Peel back the tab with the circle to open the nasal spray. Hold the naloxone with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Tilt the person's head back and support their neck with your hand. Gently insert the tip of the nozzle into either nostril until your fingers are against the bottom of the person's nose. Press the plunger firmly to spray the entire dose of naloxone into one nostril. Remove the naloxone from their nostril after giving the dose. Step 5, resume CPR. It may take several minutes for the naloxone to kick in. Brain damage can occur after 3 to 5 minutes without oxygen. You will need to perform CPR again until the naloxone kicks in. Continue giving CPR until they are breathing on their own or emergency medical services arrive. If the person has not woken up after 3 minutes, give them a second full dose of naloxone. Continue CPR or until emergency medical services arrive. Step 6, follow up. If the person is dependent on heroin or other opioids, they may go into withdrawal after you give them naloxone. Withdrawal symptoms can include vomiting, diarrhea, sweating, and agitated behavior. This may be unpleasant and dramatic, but it is not life-threatening and only lasts until the naloxone wears off. Tell them that naloxone wears off in 30 to 45 minutes and there are still drugs in their system. Within 90 minutes, the withdrawal effects will be gone. Watch the person for at least an hour or until emergency medical services arrive in case they go back into overdose. When they wake up, keep them calm. Recommend that they seek medical attention and help them if necessary. Do not let them use more heroin or other opioids. The naloxone will block it and they could overdose again once the naloxone wears off. Recovery position. If you have to leave the person at any point, put them in the recovery position. Roll them over slightly on their side. Bend their top knee. Put their top hand under their head to support it. This position should keep them from rolling over onto their stomach or back so they won't choke if they vomit. Risk for opioid overdose. Opioid overdose is most common after taking a break from using them, when mixing drugs, especially combinations of downers like heroin, methadone, or other opioids, alcohol, or benzodiazepines. When someone has been sick, tired, run down, or dehydrated, and when someone uses stronger drugs than usual. Review. If you think someone is overdosing, number 1, check for responsiveness by rubbing your knuckles hard on their chest bone. Number 2, request medical assistance immediately. Number 3, CPR. Number 4, give them a first full dose of naloxone. Number 5, continue CPR. Number 6, give them a second full dose of naloxone if they have not woken up or started breathing. Number 7, after they wake up, monitor them to make sure they do not overdose again. Number 8, put them in the recovery position if you have to leave. Refills. Ask your trainer how to get refills in case you use your naloxone and need more. In Oregon, after you complete basic training on naloxone, it is legal to carry and use it on someone who is overdosing.
administration of this, very similar to the Baqsimi. It's just giving the full dose. I think somebody asked in one of the previous classes whether or not you need to keep it in the nostril for a period of time, sort of like with the EpiPen, keeping it, held in place there. The answer is no. Once the plunger's been fully depressed, the full dose has been released into their nostril. Then, it's not a slow push. You can just, push it as fast as it'll go in there and it'll get up in there. You may also notice that there's a lot of sort of intermingling between CPR protocols and Narcan, because just the way that people typically present in opioid overdoses, if it was not a witnessed event, you're oftentimes just going to see somebody on the ground, unresponsive, and can barely tell whether or not they're breathing. They may look like a heart attack. Now, I know in our demographics, the likelihood that a child has had a cardiovascular event, and that's the reason they're down and unresponsive, is less likely than in the general population. The video is really addressed for more of a general population, in which case, yeah, you may not know. So we're going to err on that side of, well, we're going to support this person's, circulatory system doing, CPR, rescue breathing, and compressions to circulate the remaining oxygenated blood throughout the system while we're getting Narcan going. But if it is a known overdose or a witnessed overdose, you go right to the Narcan. The CPR is not a thing unless you're literally by yourself and there's no one else, around, or they have to go get the Narcan. Then while you're there, yeah, feel free to support their circulatory system by, doing chest compressions and rescue breathing. Using Narcan in a situation in which that is not the cause of their, depressed respiratory rate or level of consciousness is not contraindicated. It's just like epinephrine. Better to give it than not, right, and err on the side of, well, let's just see if this is an overdose. It's sort of a diagnosis by, exclusion, like, okay, well, we gave Narcan and they haven't come back around. Suddenly you're starting to think this is less and less likely of an overdose situation, although you would still, if you had a second dose, repeat, another dose while still doing CPR and see if it was just a function of, they needed a second dose. But you're not going to do harm to this person if they are unresponsive or have a really depressed respiratory drive by giving Narcan. So never hesitate to do that in any of those situations where they're down. But yeah, if you were to walking through the halls late one evening and see that a student, is down on the ground, yeah, we're going to be thinking kind of like, okay, this is kind of our normal CPR type of protocol, shouting for help, asking somebody to go get the AED and the Narcan, getting 911 services activated, and in the meantime, if we have access to Narcan, give it, see what happens. This will also be good information for first responders when they show up to kind of help them be like, oh, hey, you gave a dose of Narcan, 2 doses of Narcan, and nothing happened. Okay, now we're thinking differently than if they showed up and they're presented with the same patient. They're thinking, okay, we're starting from scratch. So, yeah, don't hesitate to use this.
We're going to move on to some diabetic medications. So first, just a little video.
Chances are you've probably seen me around the halls of school, in classes, or on the tennis court.
From the outside, we look like every other kid here. I Bollywood dance, and Charlie does gymnastics, just like other kids. But on the inside, we have type 1 diabetes. Diabetes isn't contagious, so you can't catch it from anyone except for one another at lunch. In fact, no one really knows why some kids get it and some don't. So far, there is not a cure. But we can stop the symptoms, and when diagnosed, type 1 diabetes is manageable. Having good management can keep me healthy and strong, just like you. So I bet you're curious, what is type 1 diabetes?
An organ in your body called the pancreas produces an important hormone called insulin. Insulin is what turns the food you eat into energy. We all know how important energy is to kids, but my body doesn't make any insulin. So when I eat, the sugar in my blood never turns into energy. The blood sugar levels just get higher and higher, no place to go. If left untreated, my blood sugar levels would go through the roof, putting me at risk for organ damage to my heart, liver, kidneys, and even my eyes.
But don't worry, luckily there are ways I can add insulin to my body and keep my blood sugar levels within my target range, just like yours. Throughout the day, I check my blood sugar levels. There are 2 ways to check blood sugar. Some kids use a glucose meter and others use a CGM. You may see me checking my blood sugar in the classroom before I eat or begin any kind of physical exercise. Keeping blood sugars in range for someone with type 1 is very important. Each person has a set target range. Once I know my blood sugar levels, I can determine how much insulin I need to give.
Kids with type 1 diabetes give insulin shots several times a day or use a device called an insulin pump. You'll see me give myself insulin before meals and to correct when I'm above my blood sugar range.
I use multiple daily injections through an insulin pen or a syringe. It hurts a little, but I'm used to it.
I use a pump and I wear it on my belt or put it in my pocket. There are many models out there and might even look like cell phones. Others use a patch pump where a pod-like device holds the insulin and using Bluetooth talks to the device. The pump gives me a small, steady dose of insulin through a small plastic tube inserted into my skin. When I eat, I just push this button and it gives me an extra amount of insulin.
Sounds simple, right? Not really. I'm a kid, not a scientist. Figuring out how much insulin I need depends on math and a lot of other factors that my diabetes healthcare team figures out for me. They include how much I exercise, what I eat, my blood sugar level, my stress level, if I feel like I am getting sick or have an infection, even how I am growing.
When I play tennis, I check my blood sugar before, during, and after the match.
I love to have a sleepover, but I have to be careful when I'm playing and having fun that my blood sugars don't drop too low. I need to have snacks ready. It takes a lot of hard work to keep my blood sugars in the target range. I can do everything my doctors and parents tell me to do, but it still can go too high or low. It's not my fault. There are basically two different problems I face with my blood sugars within range. The first is if my levels become too high. I may need your help. A few of the most common symptoms that tell you my blood sugar levels are too high are thirst, inability to concentrate, frequent urination, and or blurry vision. High blood sugars in the short term won't put me in danger right away. So if you see these warning signs, don't panic. But if my blood sugar is high over an extended amount of time, then we've got a big problem.
If you recognize the signs of high blood sugar, and we've confirmed it's high by checking it with my glucose monitor and or my CGM, give me water or a sugar-free drink. Continue to monitor my blood sugar levels to keep me from engaging in physical activity. If my blood sugars are extremely high, immediately call my caregivers or physician. Additional insulin should only be given if specifically instructed to do so.
The other problem I can have is if my blood sugar drops too low. This is much more dangerous because I can become confused and I can become severely low very quickly.
If this happens, I face unconsciousness and I won't be able to raise my blood sugar by myself. I will need immediate help.
Here are some symptoms to look for if you think my blood sugars may be going low. Shakiness, sweating, irritability, and drowsiness. The most severe symptom of low blood sugar levels are convulsions, seizures, and unconsciousness. If I do become unconscious, immediately give me an emergency dose of glucagon and then call 911.
Low blood sugar levels are considered anything below 70. In this range, some kids will start to show symptoms, while others may still feel perfectly normal. Take action based on the readings and not just how I may or may not be acting. If you suspect I might be experiencing low blood sugar levels, or if I tell you I don't feel well, help me treat my low blood sugars with fast-acting sugar. If I need to go to the nurse's office after I treat my low, have someone accompany me. That way, everybody knows I'm safe.
There really are so many different reasons of why my blood sugar fluctuates. I do my best to avoid this, but sometimes it just happens.
If I'm experiencing a low or a high blood sugar, I'm really not feeling like myself, and that affects my ability to think properly. It requires time to come back into range, and I may need to reschedule a test or finish an assignment.
By reviewing the signs and symptoms of these regularly and how to treat these, you can prepare yourself in case of an emergency. We're regular kids. We just have type 1 diabetes.
So don't be afraid. Learn all you can. And smile at me the next time you see me because I'm just like you.
If you have specific questions about a child in your care, contact the relevant diabetes provider and go to the JDRF website.
important thing to note, clinically, hypoglycemia or low blood sugar is 70 for here, school system, we keep it at 80, give a little cushion there. And next we will talk about the emergency medication that they mentioned in that video, and give you a little sample. This is the actual med, this is our, not gonna be a sample. You're not gonna taste it or anything. It lets you play with a trainer, not sample. So I will give you a little more detail on what exactly it is, but we'll watch the video first.
Welcome. Today we're going to show you how to use Baqsimi. Show your family members, friends, and people you work with where you keep this device and explain when and how to use it. It is important they know how to use Baqsimi before you need it. Keep Baqsimi in the shrink wrap tube until ready to use. Remove the shrink wrap by pulling on the red stripe. Open the lid and remove the device from the tube. Caution, do not press the plunger before insertion into the nose. Otherwise, the single dose in the device will be lost. Hold the device between fingers and thumb. Do not press plunger or test device. Insert the tip gently in the nostril until the fingers touch the outside of the nose. Push the plunger all the way in with your thumb. The dose is complete when the green line on the plunger no longer shows. Remove the tip from nose and throw away the used device and tube. If the person with low blood sugar is unconscious, turn the person to their side. Call for medical help right away. Encourage the person with low blood sugar to eat or drink a high sugar snack like regular soda or fruit juice as soon as they can safely swallow. For questions or more information about Baqsimi, ask your healthcare provider. Share this video with people you count on so they can be prepared.
So Baqsimi is, you'll see it looking like this, and it is carried on the student. We will note on all HMPs where it is, but most of the time it's gonna be like just in their little pack if they have a device for their pump. Think of, it's essentially the medication is glucagon, the brand name is Baqsimi. It's the same thing though. Think of it like acetaminophen is the drug, Tylenol is the name, same thing. So the drug is glucagon, which is just like in the video, it discussed insulin being a hormone that's required to keep the blood sugar from getting too high. It is a hormone in the body that is going to help keep blood sugar levels in the blood higher. So it's gonna break down larger forms of sugar, glycogen in your body, and then put it into the blood to get it higher. It's also going to prevent you from taking up any more sugar from your blood and making it drop any lower. It is low risk for people, so if you had a diabetic student who is severely altered, or as far as seizing or unconscious, that's when we would use this. We do not check the sugar, we just assume this student is having that sort of crisis and we give it. And it is likely a fair assumption for our known diabetics. And if it is not what's going on, say there's a substance or something else, an injury, they're not going to be affected negatively by that. Like the same with our other emergency meds. We want to err on the side of caution and go ahead and give it. It is not a medication, however, like Epi, that will be stock, and for anyone else, it is solely a prescription that will be used on our diabetic students. And we do not have any extra, it is them carrying it on them. So if we have to go this route and use this, they do not need to be unconscious, but it's that they are not conscious enough to safely have anything by mouth. So if someone's dropping low and they seem, like in the video, irritable, like confused, but you can still talk to them and they can hold their head up. And even if they're a little confused and they might not completely remember everything, they're at least safe enough to swallow without choking. That's when you would still go ahead and give those fast-acting sugars by mouth. But this is in the cases where the student cannot maintain a safe airway, likely. So putting something in would cause choking. Any questions?
Will they vomit after glucagon? I know that you used to say that very often they would throw up after receiving glucagon. Is that the case?
I have not heard that experience. It would more, instead we'll see like a change in their mentation. They should start coming to.
So every student that's diabetic in our buildings will have one of these on them?
Mhm.
Okay.
And we will, in the information we send out, let you know where that's carried.
Okay, like in their backpack or in a pouch
Yeah.
or?
I think some of the students might keep it in their boxes in the health room, not
Okay.
They'll keep an extra. Sometimes they'll keep an extra
Okay.
one in the health room, but all of our students from last year, it's in their backpack.
Okay.
So our hope is that you won't need to use this, but, it is there, and, if you are feeling you need to use this is a 911 emergency, call health services, call emergency services. We want them to get to the hospital afterward if we are having to use this.
Like after administer and call 911?
Yeah, you wanna do that first.